Good evening, everyone. It's a pleasure to take part of this excellent session, and I want to thank my good friend and colleague Laura for the initial overview. I'm going to talk about potential applications and challenges for the use of MSCs in sports orthopedics, focusing on clinical aspects. And if you want to learn more about the applications of orthobiologics in sports medicine, you can look at their these two books, and especially the one coming out next few days on basketball sports medicine. It's a very exciting time as ESCA has launched its new initiative, a long-term project, and I'm proud to be part of this excellent group with Laura, Peter Angele, and Philip Niemeyer, and definitely an exciting time for orthobiologics in Europe. So I understand, following Laura's talk, why MSCs, and it's been recent interest in harnessing biology to augment healing by improving the biomechanical quality of the healing tissue and get the healing process into generating native tissue. And we've learned that MSCs have the potential to contribute to tissue regeneration directly by differentiation into damaged cell types, or indirectly by stimulating angiogenesis, limiting inflammation, and recruiting local tissue-specific progenitors. And as we've learned, there's a wide variability in sources for MSCs, but irrespective of tissue source, MSCs can be driven to variable lineages, for example, chondrogenic, osteogenic, or tenogenic, among other lineages, through laboratory culturing by supplementation with lineage-specific growth factor combinations. And this is all in practice in various fields, not only in orthopedics. In terms of sources, the most commonly used sources for MSCs are bone marrow, still the most commonly used source and most studied, and adipose tissues, fat tissues, which is the other main source of MSCs, also referred as adipose-derived stem cells, or ADSCs, which have been shown to have a higher yield than bone marrow MSCs, shown to possess up to 300-fold more stem cells per volume when compared to BMAC, for example. And other sources have been studied, but mainly if you look at bone marrow and fat tissue, they can generate concentrated tissues, or aspirates, or they can be expanded into generating higher concentrations of cells. Another recently explored field is tissue-specific stem cells, and is a promising area, but however, still needs to be further studies. Matsumoto and colleagues have shown that human anterior ACL-derived vascular stem cells have been identified in the septum region of ACLs, shown to contain a population of stem cells, and theorized they might have a role in ACL healing. And Rindelli showed the potential in harvesting tendon tissue from injured rotator cuff, and they have been shown to undergo differentiation into different cell types. However, that's also difficult to do from low-quality tissues obtained during cuff surgery. So what do we know about stem cells use for common sports injuries? Well, the most common injuries in most sports are muscle injuries. And there aren't clinical studies looking at MSC's application for muscle injuries, but there's one recent study looking at the use of exosomes derived from PRP and MSCs. And in a rat model, they have shown that these exosomes can facilitate recovery after a muscle strain injury due to factors that can modulate inflammation, fibrosis, and myogenesis. Now, if you look at ACL injuries, which are maybe not the most common injury, but definitely one of the most devastating injuries in sports, the use of orthobiologics has been studied in recent years through a focus on PRP mainly, with several studies showing its potential in augmenting graft maturation and ligamentization, graft tunnel healing, and donor site healing. However, in terms of clinical studies, there's only one study, very low-level study from Chris Centeno and his group, looking at 10 patients treated with fluoroscopy-guided BMC and PRP injections, showing good clinical outcomes and good healing on MRI assessments already after 3 months. However, there are still many challenges when you look at the use of MSCs for ACL injuries. We still have insufficient, inconsistent evidence for the use of orthobiologics for ACL injury management. And we need more studies, more basic science studies, looking at their role, orthobiologic product roles for these processes in ACL healing. Martha Murray has done excellent work, basic science work. She has a current ongoing clinical study for her Bear technique. However, we need more evidence when we look at ACL repair, and we need to better define the optimal criteria for these procedures. So we also need to remember there's great heterogeneity in the characteristics of the various products that we want to use, as well as the different populations that we're targeting, because everyone is different. How about tendon disorders? Well, this is definitely a challenging topic in sports medicine, both acute injuries and chronic injuries. So the management of tendon injuries is challenging and often leads to suboptimal outcomes. And the regenerative process in tendon injuries is highly in favor of the fibrotic healing, scar tissue generation, compromising the biomechanical properties, elasticity, and promoting adherences. So MSCs yield growing interest for tendon repair and regeneration, try to tilt the balance towards better tissue generation. And they can differentiate into tendon cells, but they can also indirectly secrete several cytokines that modulate inflammation, reduce inflammation, enhance a regenerative tissue, better regenerative tissue healing. Several clinical studies have been done mainly on rotator cuff tissue. 2 studies coming from South Korea, one a non-comparative study, 12 patients for partial cuff tears showing improved clinical outcomes. However, they haven't shown substantially reduced tear area on ultrasound. And when they compared the administration of BMAC, PRP, and PRP compared to conservative treatment, they've shown improved outcomes. But again, in terms of tear size, non-significant differences. Another study looked at a population of glenohumeral arthritis with and without cuff tears, showing improved outcomes following a bone marrow concentrate injection. However, no differences have been shown between the OA and OA plus rotator cuff groups. Other clinical studies have shown benefit of bone marrow mononuclear cells on rotator cuff healing, as well as a larger study by Hernigu and colleagues and 45 patients with 10-year follow-up as an adjunct therapy following rotator cuff repair, reporting enhanced healing rates and improved quality of the repaired surface, assessed both with ultrasound and MRI. And some promising results for patellotendinopathy, both with BMC injections and skin-derived tenocyte-like collagen producing cells. And for Achilles tendinopathy, non-insertional, with stromal vascular fraction injections compared to PRP. MSCs were used also in Achilles repair with some very promising results in 27 patients following repair and augmented with BMAC, with 92% of patients reporting to returning to sporting activities. And for plantar fasciitis, several studies have looked at the benefit of using amniotic-derived products, showing some promising results. Tennis elbow, another common tendinopathy, with several studies, mainly case studies or a small case series, showing potential, as well as the use of allogeneic adipose-derived stem cells injected for tennis elbow, showing some good results. Still, there are many challenges when you look at the use of MSCs for managing tendon disorders. One of them is the heterogeneity of clinical presentation for patients with tendinopathy. There's difficulty in developing animal models, which we can translate to clinical practice. There's still lack of agreement on the pathophysiology of tendinopathy. And there's inconclusive evidence for certain pathologies and anatomic sites which limit the incorporation into clinical practice. And also there's the regulatory environment surrounding stem cell therapies, which complicates the development of new clinical solutions. Meniscus injuries, another challenging field. You look at sports orthopedics, and various sources have been studied in preclinical studies. starting from bone marrow MSCs, adipose-derived stem cells, synovium-derived stem cells, and meniscofibrocondrocytes or meniscus-derived stem cells, and even cartilage-derived chondrogenic progenitor cells more recently. They've all shown some promising abilities in meniscal tissue regeneration in preclinical studies. In terms of clinical studies, not too many. Double-blind RCT with a 2-year follow-up of 55 patients who underwent partial medial meniscectomy and were assigned to 3 different treatment groups, either an injection of 50 million allogeneic MSCs suspending in hyaluronic acid. The other group received 150 million allogeneic MSCs with suspended in hyaluronic acid, and control group received only hyaluronic acid. And both MSCs groups experienced a significant meniscal volume gain assessed on MRI at 1 year post-implantation, although over time, 2 years, this has gradually decreased. Another study in 17 patients with past meniscectomies received an implantation with an acellular polyurethane scaffold with and without MSCs. And they showed that the addition of MSCs did not provide any advantage in protecting articular cartilage over the acellular scaffold without the MSCs. Another small case series, 5 patients treated with autologous MSCs from bone marrow, seated on a collagen scaffold, showed mixed results in the study from the group from the Bristol area. And a more recent direction explored was the application of autologous synovial MSCs transplanted onto the menisci of 5 patients with some improved clinical outcomes at 2 years. And this is how it looked. And this has been done 2 weeks after repair, applying the autologous synovial MSCs. Probably the most applicable study by Tomasz Piątek and his group from Poznan, Poland. They administered in 54 patients with complex meniscal tears, treated with meniscus sutures and meniscal wrapping with a collagen membrane, the chondroguide membrane, along with bone marrow blood injection into the or under the membrane, reporting statistically significant improvement, clinical improvement, as well as MRI features. Also, they had reported, which was pretty impressive, an overall survival rate at the final follow-up of 88%. Still, there are many challenges. We look at the use of MSCs for meniscal tears. Many studies have explored different source types. While these sources exhibited some promising properties for meniscal healing, some of them also possess properties which can cause hypertrophy. And this has been shown for bone marrow derived stem cells, MSCs. And the challenge of hypertrophy and mineralizations arises when discussing the use of especially bone marrow MSCs, but also other sources. And this needs to be better understood, how to balance these abilities of these different MSCs from different sources. If you're a Star Wars fan, you can use this analogy and consider orthopedic surgeons involved in orthobiologics for tissue regeneration as young Jedi apprentices learning how to control the Force and control their lightsabers. And we need to learn how to balance these great powers and learn how to find a balance between the Force and the dark side of the Force, if you wish. So that's definitely a challenging and promising field, and we are definitely in our early stages of training. So to summarize, the use of stem cells in sports medicine is promising, tremendous growing interest. Cell-based therapies have an immense potential to improve healing of soft tissue injuries in the athlete. However, there's still significant knowledge gaps. And due to the worldwide exponential growth in cell-based treatments without standardization and transparency, an international expert consensus proposed the DOSIS tool for describing cell therapies to allow for better assessment in future studies and comparison between different treatments and techniques. We need to better standardize treatments because until we do that, athletes may be at risk for serious adverse effects and complications. And we definitely need future research to optimize the treatment protocol for each type of injury in regard to preparation techniques, dosage, delivery, and rehabilitation. And we should better define the best indications and applications for biologic therapies in a way that maximizes both the benefit and the safety for the athlete and any patient. Thank you very much, and hopefully we'll see you soon in some of our activities during the next ESCA Congress in Milan, hopefully in 2021. Thank you.